Next, pleasure to bring up Nancy Major. A year ago, we were really fortunate to have Nancy and her husband move to the Boulder area. She was previously chief of the musculoskeletal radiology at University of Pennsylvania and previously at Duke. Loves sports, is here with us at the Champion Center. And Nancy, come on up. Thank you.
Well, thanks for having me back, Eric. And every time I hear you speak, I always want to leave by saying, "Ready, break." You're just so enthusiastic, and I greatly appreciate it. So, but in the next 15 minutes, I'm going to try to offer to you how MR helps in evaluation of a painful hip in an athlete. So there are a few things that I thought I would focus on in the next 15 minutes, starting first with fractures, moving on to some soft tissue injuries, and then concluding with a labrum and FAI. So first, as we evaluate fractures, there are two that I really wanted to bring to your attention. Obviously, the femoral neck stress fracture, which can affect either the compressive or the tensile side. And then I'll move on to talk about sacral stress fractures. And you can see in this example of a T1 and a fat-suppressed T2 weighted image that we're demonstrating a stress fracture on the compressive surface. So a very nice demonstration of the fracture line with bone marrow edema. Another example here, and it's one of the reasons why we do a couple of different types of sequences so we can see the fracture line. Sometimes it shows up better on one sequence versus another. Not too easy to see on the image on your left. That's a T1 weighted image, large field of view, but much easier to see the fracture line with the bone marrow edema on a fat-suppressed sequence, which we refer to in the musculoskeletal section as the cheater sequence. It means that basically we wipe out all of this signal, make the image dark, and so everything that's bright should conceivably be abnormal. But I don't want to give all of our secrets away. So in this example, this is a recreational runner, ran about 20 miles per week, presented with groin pain, and you can see the left image is a T1 weighted image, and the gray area is the bone marrow edema. But in addition, there's a little periosteal reaction. You can see that also on the fat-suppressed T2 weighted image with the bone marrow edema and the periosteal reaction. But the fracture line is not well demonstrated. But that is on the axial images, so it's a reason why we do both coronal and axial images. Fracture line much easier to see in this particular case on the axial images because the coronal image just coincidentally went right through the fracture line. And this is just a nice case to remind us that we're not always talking about the thin, long-distance runner who gets stress fractures. This was an older woman who was just recently getting back into exercise, and you can see kind of by her size, and she's a little bit chubby. And she, in fact, didn't quite fit into our usual magnet. We put her in a wider bore magnet, which is why the image looks a little bit fuzzier than some of the other images I showed you. But you can see when she presented with groin pain, easily demonstrated is her stress fracture. Now, one of the things to keep in mind and that we have to keep in mind in your clinical history and how you're examining the patient is really helpful to us. This is a patient who's an ultramarathoner, one of my colleagues, in fact, in radiology, and he ran a lot of the 100-mile races, was preparing, in fact, to come out to Leadville and run that race, but he was walking around the department looking like he was about 9 months pregnant with SI joint symptoms and really waddling around, and I have to say, complaining way more than any pregnant woman I'd ever heard. So we popped him into the magnet, and we can see on the T1 weighted images, so just look very carefully at these images. Do you see how now with the arrows there, you can see a slight difference in the appearance of the bone marrow, a little bit darker on the T1 weighted image, very conspicuous on our cheater sequence of fat-suppressed T2 weighted images because the bone marrow there, the edema is quite bright. So this is a classic finding of a sacral stress fracture. However, most of the time, we don't get that really great history and the constant whining from the men. This is a more usual situation. This was a varsity tennis player, a female, who finally, after a few weeks of not being able to sleep comfortably at night, went to see the sports medicine team, and a lumbar spine MR was recommended. So this is what we typically see. And the only thing that may have tipped us off to look a little bit more closely at this was her age, because we were asked to look for some potential pars defect or something that a young individual would present with. So the difference between this case and the last case I showed you is this doesn't have the cheater sequence. We typically don't have a fat-suppressed image in our lumbar spine imaging. So let's look very carefully. The images on your left are T1 weighted images. Comparing the left side to the right side, you might now appreciate that it's a little bit darker in that the left hemisacrum. When we look at our T2 weighted image without the fat suppression, so a non-cheater sequence, you see that little black line? So that's the fracture line. So she presented with a sacral stress fracture after her constant training with tennis. And again, the fracture line is a little bit easier to see on that sequence, but we had to actually look for this. So very easy in sort of general practice to just blow right by this. So the clinical history, the fact that she's a varsity tennis player, the fact that she's very athletic, was incredibly helpful to us in making that finding. Here's another young individual who presented with SI joint pain. One of the things that we might think about in a young individual with SI joint pain is obviously a spondyloarthropathy. So looking at these SI joints, they look totally normal. So we recommended the patient go on to have an MRI. And you can see kind of that triangular area of low signal in the left hemisacrum. Let's look at the cheater sequence, and the cheater sequence, in fact, also shows us the fracture line a little bit easier. The images through the sacrum, because again, we were thinking perhaps a spondyloarthropathy, shows the bone marrow edema with the fracture line quite nicely. But does anybody see anything else on any of these films? Look at the image on the bottom. Do you see that focus of bone marrow edema? No, we just talked about stress fractures along the femur. So she has two foci of bone marrow edema in two sensitive locations. So in this dictation and our final report, we recommend, of course, that she get a bone densitometry study in addition to the diagnosis of the two fractures, that perhaps she's falling into the female athlete triad syndrome. So now let's talk about some soft tissue abnormalities, and specifically I want to talk about hamstring injuries first. So this is a young individual who had a hamstring avulsion, and you can see in this example that the hamstring is still attached to a portion of the apophysis, and the fluid signal there tells us that this is a relatively acute situation. Obviously a pretty easy plain film finding. In this example, I have to say that we get a lot of requests for evaluation of sciatic disease and lumbar spine studies, but what is underappreciated in many of our adult patients are these high-grade partial tears of the hamstring, which can present as annoying butt pain, often interpreted as sciatic abnormalities. So two different appearances of hamstring abnormalities. Greater trochanteric bursitis is something we see quite frequently, where patients present with pain in the lateral aspect of the hip, usually due to repetitive hip flexion, and the presentation can mimic gluteus medius tendon tears, often treated with nonsteroidals or a steroid injection, and then finally best imaged on our cheater sequence. So here we have a gorgeous demonstration of a greater trochanteric bursitis. But when we look at that as a musculoskeletal radiologist, that's the tip-off for us that we need to look for tendon pathology. And immediately adjacent to that, we can see a tear of the gluteus medius tendon. And this is an individual who is a kickboxer presenting with hip pain and a subtle finding there of the indirect rectus femoris tear, which we see both nicely on the coronal and axial images. Getting back to what Dr. Mayer said, it's hard to know what we have to call these things. Just keeping up with the terms in the literature is exhausting enough. But basically, we see an imbalance in the sports hernia or athletic pubalgia syndrome between the rectus abdominis and adductor muscles, may appreciate symphyseal instability. And the patients can present with either pain in the symphysis, hip, or back. You can see in this individual what we're looking for on MR on our fat-suppressed T2 weighted image, aka the cheater sequence, that there's fluid signal along the symphysis and also undercutting the adductor tendons as they insert onto the pubic symphysis. Another example in this professional hockey player, look at the fluid signal in the symphysis. Normally that's just a nice area of gray and not the bright white, and it's undercutting the adductor insertion on these consecutive coronal images through the pubic symphysis. So that's how we would make this diagnosis of athletic pubalgia. And finally, let me just finish up with the labrum and FAI. You'll hear a lot more about this in future lectures. For us as radiologists, we really do need to understand the anatomy in order for us to know both where something is located on the image and what it's supposed to look like. What is the normal signal intensity? So the labrum is a rim of fibrocartilaginous tissue that surrounds the acetabulum, and it should be uniformly low in signal, or black, and triangular in configuration. We know that it's thicker at the posterior superior aspect and thinner as you move around anteriorly and inferiorly. And inferiorly, it blends with the transverse ligament at the notch. Anteriorly and posteriorly, the joint capsule attaches directly at the base of the labrum. That's very important for us to recognize as radiologists. However, superiorly, the capsule can insert several millimeters from the labrum, creating a paralabral recess, as we can see on these two coronal images. So there we can see the capsule inserting just above the labrum. And in this example, where a patient has a little bit of fluid in the joint, that can actually mimic a labral tear if you're unaware of the normal capsular insertion. Patients present with persistent pain, clicking, may have a decreased range of motion. The labrum can be injured from a single traumatic event associated with chronic stress or dysplastic hips. Now, there is a spectrum, especially that we're starting to really appreciate between dysplasia and impingement. And one sort of simplified way of thinking about this is that in dysplasia, the acetabulum can be too small, deficient, or deformed. With impingement, the acetabulum might be too big or retroverted, or the femoral head may be malformed. Let's look at DDH, which is not an uncommon finding, as we look at painful hips in the athlete. This is a very globular, abnormal signal to the labrum. Remember, I said it was supposed to be a triangular-shaped area of black, and this is gray and very globular in its appearance. Let's look at this example. A little fluid in the joint space outlines that we don't see a triangle. We see this globular gray area of labral tissue, and in this image there, the fluid in the joint space going right through the detached labrum. So what we'll look for on MR is linear diffuse high signal, deformity of contour, detachment from the acetabulum, as I showed you in that example, and the presence of a para-articular cyst. Most tears we know occur in the anterior superior labrum. Posterior and posterior superior tears are more common in younger individuals and in Asian countries. And the other thing we need to be aware of is if we identify a labral tear, we are on the hunt for a chondral abnormality, which occurs in about 1/3 of the patients. There are some mimickers, and the most common mimicker of a labral tear is the appearance of the iliopsoas tendon as it crosses over the labrum. Additionally, we can see the acetabular cartilage extend medially, and then finally, we know that there are sublabral recesses. Here's an example of the iliopsoas tendon as it crosses over the labrum. I'll blow it up for you here, and we see the low signal of the tendon crossing over that triangular low signal of the labrum, and the area in between to the novice may be interpreted as a labral tear. Another example of a labral tear in this tennis player, where you can see the fluid inspissating between the bone and the detached labrum. And these are consecutive coronal images demonstrating a labral detachment in this patient who injured herself demonstrating yoga. Finally, the oblique axial images are extremely helpful for us in recognizing labral pathology, as it lays out the joint the way that we would typically have it in the body. So here's the labral tear demonstrated on the coronal images, and the oblique axial images demonstrate the abnormal configuration, abnormal signal intensity, and the detachment from the acetabulum. This is a patient who presented with left hip pain. The plain film was entirely normal, went on to get an MRI, as we often recommend, particularly in the athletic population. And there's a constellation of findings here that helps us make the diagnosis of impingement. We can see that there is labral detachment, but look at that presence of that bone marrow edema in a classic location where that portion of the femoral head-neck junction would collide with the acetabulum, resulting in the labral tear and an associated chondral lesion. And here we can see the labral detachment. So I know that we're going to hear a lot about femoroacetabular impingement, and I just want to show you a couple of examples as I'm getting close to running over my time. The Pincer example of femoroacetabular impingement, where there's overcoverage of the acetabulum, is demonstrated here in this example, where you can see the rub and the development that can often occur with synovial herniation pits. One of the things we look for is the presence of a contra-coup injury or the chondral abnormality that we look for on the posterior aspect of the acetabulum. In this example here, where we now talk about cam impingement, that's the normal appearance of the femoral head-neck junction, and here is the bony protuberance that we see with the bony pons of cam impingement. And I'm going to conclude right there. I only had a couple of extra slides anyway. Thanks so much for your attention.